Welcome to today's webinar, Pumping Iron, Not Prednisone, a prescription for exercise and rheumatic disease. I'm Joyce Kullman, Executive Director of the Vasculitis Foundation. We are glad you could join us today. A few housekeeping items before we begin. Please ensure you click on the full screen icon in the upper right-hand corner of your computer screen in order to capture the optimal screen resolution for today's presentation. After the presentation, we will host a Q&A session. You can submit your questions through the chat window or question box, and we will address as many of them as possible. Before we begin today's presentation, I want to invite everyone to attend our 2017 International Vasculitis Symposium, which will be held in Chicago, Illinois, June 23rd through the 25th, 2017. The symposiums are held every other year, and they are a 3-day activity with days and days of educational meetings on everything from diagnosis, treatment, and also research updates, recent findings, what we've learned, what we need to learn, etc. The symposium includes general session topics for the whole audience, as well as smaller breakout sessions to discuss items such as organ involvement, fertility and vasculitis, eyes, kidneys, lungs, you name it, we will be covering it at this year's symposium. The registration and hotel information can be found on the VF website at www.vasculitisfoundation.org. The other item I wanted to mention is our 2017 Vasculitis Awareness Month, which is May 1st through the 31st, 2017. Vasculitis is a family of potentially life-threatening diseases linked by blood vessel inflammation and a dysregulated immune system. We believe everyone should know about vasculitis. Just because it's a rare disease does not mean that people should not know about vasculitis. We encourage members of our vasculitis community, from our patients, their family members, our physicians and researchers, to do something during Vasculitis Awareness Month to raise awareness of the disease and the impact that it has on people's lives. You can find information on Vasculitis Awareness Month and activities that you can do on our website. We hope you'll visit. You know, it can be anything from sharing a poster, changing your Facebook icon for the month, sending out an email blast to your family, wearing a VF t-shirt to your next doctor's appointment, having a fundraising event, hosting an awareness event. Anything goes during Vasculitis Awareness Month. It is an international activity. Patients all over the world participate, and we hope that you will too. Another item we have is our Team Brandon, and we thought this was important to share with especially with today's topic of getting back into exercise. Team Brandon is our program built around Brandon Hutchkins, who is a professional miler. He's a long-distance runner, and he is leading Team Brandon, and you can join him on Facebook. This year's program as part of Awareness Month is Define It, Do It, Share It. What is your victory over vasculitis? And this can be anything from running a 5K to spending the weekend with your grandkids. What have you found that you can do? So many times vasculitis impacts a patient's ability to do things. So we are hoping that during Vasculitis Awareness Month and then the rest of the summer that you will share with us what is your victory over vasculitis. At this point, I'd like to introduce Dr. Rebecca Manno to the presentation. Dr. Manno is an assistant professor of medicine and assistant director of the Johns Hopkins Vasculitis Center at Johns Hopkins University School of Medicine. Her research interests are focused on the intersection of aging and rheumatic diseases and the application of assistance or resistance exercise for patients with inflammatory disease, namely rheumatoid arthritis and vasculitis, to improve body composition, strength, function, and decrease inflammation. Dr. Manno originally presented this information at our Regional Conference in Bethesda, Maryland, February 4th, 2017. We are pleased to welcome her to this webinar, and we appreciate her sharing her time and knowledge with us. Dr. Manno, you have the floor.
Great. Thank you so much, Joyce, for the invitation, and I want to thank the Vasculitis Foundation for the opportunity to talk about one of my favorite topics, which is exercise and rheumatic disease, but specifically we'll talk about how it applies to vasculitis. So I don't have any disclosures that are relevant to this talk, but I always feel that I have to start by putting up this disclosure, which is that I won't be discussing nutrition today. Nutrition and exercise go hand in hand, and so it's really difficult not to talk about them in the same presentation, but in the interest of time, I'm going to stick with just exercise. But nutrition is really always important whenever we're thinking about exercise, fitness, body composition, and strength as well. So over the next 45 minutes or so, I'm going to share with you some of the current data in exercise and rheumatic disease, talk about some ways to prescribe exercise. We're really good at prescribing medications, but how do we prescribe exercise for vasculitis and other inflammatory conditions? And then let's acknowledge some of the barriers to exercise knowledge and implementation. So when I show this slide to a group of physicians, everybody nods their head and agrees with me. Exercise is good for our patients. But this wasn't always true. We didn't always at least take this as a truth. So I just want to spend a few minutes talking about a brief history of the world of fitness, and what we take as a given for today hasn't always been the case. So let's go way back in time. So if we go back to the prehistoric days, the human body was meant to be in motion. Primitively, we were hunters and gatherers. Interestingly, even in early ancient Greek civilizations, there was some acknowledgement that movement of the human body was important for health. And Hippocrates, who is one of the most famous and earliest physicians, is noted to have written that eating alone will not keep a man well. He must also take exercise. Then fast forward several hundreds of years, and in the 1800s we have the Industrial Revolution. And this really changed things. So instead of a society that was farming and outdoor and active and spread out, we became centralized within large cities. We started to develop machines to do a lot of the manual labor that humans were doing previously. And it really changed not only the economic landscape of the world, but also the health of workers around the world. Then we had 2 world wars, which certainly changed things from an international standpoint. And during that time, we also had a very important development in health and medicine, which was penicillin was discovered. So infectious disease, which had been one of the leading causes of death, along with trauma and war around this time frame, became a treatable cause of morbidity and mortality. Then in the 1950s, there was some very interesting work that was published by Dr. Jeremy Morris. Dr. Morris was an epidemiologist in London, and he did what so many great epidemiologists do, which is he simply made an observation, and it was there for everyone to see, but he put it in a context. And what Dr. Morris noticed was that on the double-decker buses that serviced London, there was always 2 employees. So there was 2 workers. One was the driver, and the other was the conductor on the bus. The driver would obviously be driving the vehicle. The conductor would be walking up and down the steps all day long on the double-decker bus, collecting tolls and fare from everyone. And what he noticed was that there was a significant difference in the rate of heart attacks and death between the driver and the conductor. The next thing that he observed and noticed was that if he looked at the just the physical attributes of the conductor versus the driver, there was a difference in their pant size, their waist size of their pants, and that also corresponded with risk of heart attack and death. And this seems so this is common sense to us in 2017, but in the 1950s, it was revolutionary. To think that if you walked up and down the stairs all day for work, instead of sitting and driving the bus, that you would have a smaller chance of having a cardiovascular event was revolutionary. Also in the 50s, computers were invented, and this was about to change the face of the world. In the 1960s, Dr. Kenneth Cooper wrote this groundbreaking book, which was called an aerobics program for total well-being. And this is when you really start to see the advent of physical fitness and cardiovascular fitness trying to combat those observations that had been made previously with sedentary lifestyle increasing the risk of cardiovascular disease. And so the world of aerobics and physical fitness was born. And now it really started to come into not just the scientific community, but into the popular press. And we have icons like Richard Simmons. Personal training was really developed. Commercial gyms took off as well during this time. Different types of cardiovascular activity was promoted, like spinning classes. In the 1990s and in 1996 in particular, the federal government took notice of what was happening. And there was, for the first time, a movement towards trying to prevent disease and prevent sickness and prevent chronic illness instead of just being reactive and treating things when they happened. And so the Surgeon General came up with the first physical activity and health report. Along the same time, another important development, which was going to change how people were spending their time, emerged onto the worldwide into the world, and that was the World Wide Web. Then in the 2000s, the world of fitness just exploded. You had all sorts of new types of exercise and activity that could be found just about anywhere you went: Zumba, CrossFit. And in 2008, the Surgeon General realized that it was time to update their previous recommendations from the 90s, and this is what we currently have in terms of physical activity and health recommendations, which are listed here, and that is 150 minutes per week of moderate intensity physical activity, which is 30 minutes per day, 5 days a week, plus muscle strengthening at least 2 days per week. So here we are in 2017, now that you know where we have been. And there's just a plethora of fitness information that's out there. There's blogs, there's magazines, there's commercial gyms, and along with that there's fitness gear, and now technology has really exploded onto the scene also. So there's no doubt that we all agree exercise is good for our patients. But I get always a bit of a different reaction when I show this slide to a room full of physicians, which is exercise is good for our patients' doctors. And most of the time everybody nods their head and agrees that to be true. However, if we really look at the exercise habits of physicians, the results are pretty disappointing. So in one study that looked at the faculty of Harvard Medical School, they found a very disappointing less than 50% of these faculty members exercise for 1 hour per week. Well, you might say, it's Boston, it's Harvard, they're working a lot. That's not representative of most physicians. It's cold up there. Maybe that's why they're not getting out and doing things. But when they looked at California physicians, they found a disappointing 73% said that they didn't exercise less than an hour per week. So this seems to be more of a global problem than just in Boston. This is a small study that looked at the exercise habits of primary care physicians in Japan. And similar to the other studies I showed you, most physicians said that they did not exercise more than once a month. And if we looked at the age and the workplace of these physicians, what we saw was that, interestingly, from the age standpoint, younger physicians didn't seem to exercise much at all. And as the physicians got older, they were more likely to exercise, but it peaked around age 60 and then decreased again. Certainly where you work as a physician may influence how likely you are or are not to exercise, with outpatient physicians being more likely than their counterparts. So who cares if doctors are exercising? Why should anyone care if their physician is or is not exercising? And the reason is this study. In this study, which looked at the personal exercise habits of primary care physicians and how likely they were or were not to counsel their patients in regards to exercise for their own health. And here is the bottom line from what they saw in this study, was that physicians who exercise in an aerobic fashion are more likely to counsel patients on exercise. And the odds ratio that you see listed here in blue means that doctors who exercise were 5 times more likely than those who didn't to counsel their patients to exercise in an aerobic fashion. Similarly, doctors who strength trained were more likely to counsel their patients on strength training, and that was at least 4.5 times higher. Interestingly, older age and longer time in practice was negatively associated with exercise counseling. And I'm not sure that I can explain this, but it was just an interesting finding in the study. But the bottom line is, if your doctor is actually exercising, they probably have more knowledge about it, and they are more likely to then make those recommendations to their patients. Of course, there are always barriers that can be identified. That doesn't mean that they're insurmountable, but should be identified as to why doctors said that they did not counsel their patients on exercise. Inadequate time, which we know is always an issue in our clinic encounters, but inadequate knowledge, either about aerobic or strength training, was a considerable barrier. And this is something that we can certainly fix by increasing the education of physicians. Some physicians thought that their patients were not interested, and then some physicians were not familiar with some of the data that I'm going to share with you later that shows the benefits of strength training. And this is really the bottom line as to why it is important if our physicians are exercising or not, which is that up to 80% of the population relies on physicians for recommendations on physical activity. So whenever we talk about exercise, we have to be sure that we're speaking the same language and we're talking about the same things. So physical activity and exercise are two terms that are often used interchangeably, but they really mean different things. So the definition of physical activity is any bodily movement produced by skeletal muscles that results in energy expenditure. So these are the things that you do every day to get through your day. But exercise is different. And when we're talking about exercise, whether it's in a research study or whether it's being prescribed for a particular outcome, exercise, the true definition of exercise, is a subset of physical activity. But what's different is that it's planned, structured, repetitive, and goal-oriented to improve or maintain fitness. It's goal-oriented, meaning that we set goals before we embark on an exercise program. It's planned, it's structured, and repetitive. And what does that sound familiar to? It sounds like a prescription, right? It sounds just like how your doctor may prescribe a certain amount of prednisone or a taper or a biologic agent or other type of medication to treat a process. You take that medication in a planned, structured, and repetitive way. The same is true when we're talking about exercise. And this is why we like to think about, when we use exercise as a tool to help our patients with rheumatic disease, that it really is a prescription. It's not a suggestion, it's not an idea, it's truly a prescription. And I'm not the first person to come up with this. This idea is actually founded in the American College of Sports Medicine, where they came up with an initiative several years ago called Exercise is Medicine. And if you Google Exercise is Medicine, you'll come up with the Exercise is Medicine website, and I'm going to show you some screenshots from it. It's actually a slightly older version of the website, but it's a wealth of information about how to exercise with and without chronic diseases. So the vision of the Exercise is Medicine initiative was to make physical activity and exercise a standard part of disease prevention and treatment medical paradigm in the United States. And so the initiative was launched in 2007, but it still exists today with some additional modifications and modernizations. And the idea is that this really should be integrated into routine medical care. This is a screenshot from the Exercises Medicine website. And what you can see here is this is, I think you can see my pointer here, but you can see a list of several different chronic diseases. And if you click on any of these, you come up with a particular information sheet on how to exercise with X, Y, or Z chronic disease. In the world of rheumatology, we don't get much representation on this list. There is exercising with arthritis. Unfortunately, exercising with vasculitis does not exist yet. So if you click on one of those links, what you'll see is a form that comes up similar to this, and it talks a little bit about how to get started, what are some precautions. There is an extensive amount of literature on this website as well for your doctors and for your healthcare providers. So that from that previous study, when I showed you that one of the barriers identified by physicians was lack of knowledge, the knowledge is out there. We just have to make sure we get it in the right hands. Included in this provider resource guide is an exercise prescription, because if we're going to use exercise as a part of treatment, it should be just like we would write a prescription for a medication. It should have a dose, an amount, and if there is any plan to increase it, what that would look like. And sometimes just having an actual prescription to be able to write that down on can make a big difference. So I'll remind you of the current guidelines from 2008 from the Surgeon General, which is 150 minutes per week, which includes muscle strengthening. So this is something that I found very useful and very practical. And it's under the physician's guides, but I think it's applicable to everybody, just when you're thinking about starting an exercise program. You'll see what I highlighted is what they give the disclaimer that these are guidelines for healthy adults under the age of 65 with no apparent chronic disease or condition. And I would argue that that represents exactly 0% of the patients that most physicians are seeing in practice. But I don't think that any of these steps that I'm going to review in the next few minutes are exclusive to that population. So step one. So the first part of starting any exercise program is setting aside the time each day to exercise. Not having enough time is probably one of the #1 reasons that any of us say, I don't have time to exercise. But if you make the time, if you find the time, it doesn't have to be a lot of time. It's probably one of the biggest myths about getting started with an exercise program, which is that now you're going to have to allocate 30 minutes, 60 minutes, 90 minutes, 2 hours to a new exercise program. And that couldn't be less true. Even just committing to 5 minutes 3 times a week, you're going to see benefits and gain. Step 2, choose activities you enjoy. And especially when you're thinking about the cardiovascular activities, you got to pick something that you like, and it's not going to be the same thing for everyone. If you hate the water and swimming, although swimming is a great way to achieve fitness and it's low impact on your joints, but if you don't like the water, then that's not the right exercise for you. Walking is one of the most universal cardiovascular exercises and certainly is a gateway into fitness. Step 3, start with just 10 to 15 minutes of cardiovascular exercise daily. And this gets back to even step 1, setting aside the time. But you always want to start slow. And another one of the big mistakes that I'll see when someone becomes motivated to start on an exercise program is to commit too much time up front and to have unrealistic goals. So starting off slow, even in very small increments, you will absolutely still see benefits. And fourth is incorporating strength training into your routine. The cardiovascular part of your fitness, whether that's walking or biking or running or swimming, is very important. But you're not going to get the full benefits of exercise without some degree of resistance exercise. And similar to when you start cardiovascular, this does not have to be heavy weights, and it absolutely shouldn't be heavy weights when you begin. And it does not have to be for prolonged periods of time. So we've talked a little bit about exercise in general, the attitudes of physicians about it and some of the barriers, and how we can get started with actually a prescription for exercise. But what type of data is out there about exercise and our rheumatic diseases? So if we look at the literature and we look at the research that's out there on different types of rheumatic disease and exercise, let's just take, for example, three of the big ones, three big rheumatic diseases that are incredibly important: arthritis, myositis, and vasculitis. So if we look at arthritis, there are two big types of arthritis that we think about: osteoarthritis and rheumatoid arthritis. And if I look in the literature at what type of what data is out there on exercise and osteoarthritis, I find about over 400 articles on osteoarthritis that have been published in 2016. In rheumatoid arthritis, the autoimmune inflammatory disease, it's significantly less, but not a bad number, 72. Myositis, which is an inflammatory disease that targets the muscle, much fewer, 15 articles. And in vasculitis and exercise, there is precisely one article that has been published, which is incredibly disappointing. So I want to share with you some of the highlights of the data that is out there about these other diseases and exercise, because that may help us to create a framework as to how we think about vasculitis and exercise. So osteoarthritis is the wear and tear type of arthritis that we are all susceptible to as we get older. The risk factors for osteoarthritis include older age, being a woman, joint injury, overweight, and a family history. It can affect one joint or many joints. Osteoarthritis loves to keep company with plenty of other medical conditions, chronic diseases like cardiovascular disease, diabetes, and without a doubt, having vasculitis does not absolve anyone from having osteoarthritis. The universal recommendations by all osteoarthritis experts is that exercise is the first-line therapy to decrease pain and to preserve function. But the question that I always get asked then is, what type of exercise? And to keep it simple, it truly is whatever exercise will be done consistently, which means that you also have to enjoy it. So the consistency of any exercise program is incredibly important. Remember, it's not just the physical activity. It's having a planned, repetitive prescription that you're going to stick with over time. Along those same lines, low-impact exercise is preferred to high-impact exercise in osteoarthritis. Now, just to be clear, low impact does not mean low intensity. Low impact can be incredibly intense. It can be it doesn't mean low weight. It just means that it's low intensity. It means that there's not high velocity exercise. You try to minimize acceleration type of movements and jarring types of movements. And universally, for osteoarthritis, you want to include a resistance component. Muscle strengthening in osteoarthritis is one of the only tools that we have to unload the arthritic joint. And this can be accomplished even in the water with aquatic therapy. So what do we know about exercise in rheumatoid arthritis? So just a little bit about rheumatoid arthritis, what it is. It's an autoimmune inflammatory arthritis. It typically will affect multiple joints, and it may be associated with a certain type of vasculitis called rheumatoid vasculitis. Just an important to note is that ANCA-associated vasculitis can be associated with an inflammatory arthritis that may resemble or mimic rheumatoid arthritis. So I think this is another one of these opportunities where we can take some of the work that has been done in rheumatoid arthritis and think about it in vasculitis as well. So there are some data in rheumatoid arthritis looking at the safety and the efficacy of exercise in rheumatoid arthritis. And so with several studies, we have shown that resistance exercise or strength training in rheumatoid arthritis does not increase breakdown products within the joints, which means it's safe. There was a review of several studies that similarly showed that there were no safety issues with aerobic or strength training in patients with rheumatoid arthritis. And this has been repeated even as recently as 2012. This is just one nice study that I'd like to highlight. I like this study a lot. It's getting older and older now because it was published in 2009, but it was a very, very well done study. This study looked at high-intensity resistance training in patients with rheumatoid arthritis, and it was a randomized controlled trial. So they took patients and they randomized them either to resistance exercise twice per week for 24 weeks or to a control group. And what they found is that the folks who exercised had a 4% increase in their lean body mass, an 8% loss in their total fat mass, and they had a 25% increase in their lower extremity strength. But here's what's incredibly important, and they published this study 3 years later. So they went back to all of the folks who had completed their study, and they said, how are you doing now? You had all of these great gains while you were exercising in our study. How are you doing now? Here's what they found. They found that 0% of the patients in the study had continued to exercise, 100% of the patients regained fat, and 100% of the patients lost lean muscle. So without a doubt, this really showed in a controlled research environment what we know to be true in everyday life, which is that exercise as a intervention really is a lifestyle intervention, and it's not something to do for a short period of time. It's something to be incorporated into everyday habitual life. We also know that exercise can be helpful to battle fatigue in rheumatoid arthritis. Fatigue is one of the symptoms that we see in so many of our rheumatic diseases, and it's absolutely prevalent in vasculitis. And a lot of our medications aren't so good at treating it. However, exercise is one tool that we have, and there have been data that have supported this to treat fatigue. So what about other types of exercise? We've talked about aerobic exercise and resistance or strengthening exercises. What about yoga? So this was a trial that was conducted here at Johns Hopkins in patients with arthritis, both rheumatoid arthritis and osteoarthritis. And they looked to see the safety and efficacy of yoga for patients with arthritis. And so what they found is they randomized folks either to 8 weeks of yoga or to a wait list. And they found that the patients who did yoga had decreased pain, a better quality of life, better flexibility, and less depression. But most importantly, yoga was safe. It didn't cause flares of rheumatoid arthritis or worsen any symptoms of osteoarthritis. So the key points from the data that I've shared with you about exercise and rheumatoid arthritis is that exercise is safe even in a disease that's characterized by joint inflammation. It can be effective if it's used correctly to combat fatigue, fat gain, and muscle loss, even in a disease where corticosteroid use, sarcopenia, which is loss of muscle, and obesity are common. So what do we know about vasculitis and exercise? Well, I already told you it was going to be pretty disappointing, and in fact it is. So just a few words about the single study that is out there on vasculitis and exercise, which was a study that looked at 6 patients with stable Takayasu who were on less than 10 milligrams of prednisone a day. And they had these patients do 12 weeks of a supervised treadmill walking program. So this program did not involve any resistance exercise, and it didn't involve any other type of exercise. It was 2 times per week. What was encouraging is that in the study, they did see decreases in certain inflammatory markers. They didn't see any changes in vascular reactivity. There was not much else that they looked at in terms of outcome measures. But they didn't see any flares of disease activity either, suggesting safety. So now I just want to share with you one of my patients. And just in the real world, how we handle some of these things. So my patient is a 65-year-old woman with giant cell arteritis, so one type of systemic vasculitis or a large vessel vasculitis. She was diagnosed 3 months ago with classic cranial symptoms of headache and vision symptoms. She had a temporal artery biopsy that showed inflammation, and she also had inflammation in her aorta and her large vessels. When she came in to see me, she was on 45 milligrams of prednisone. And I look at her labs, and I look at her numbers, and I say, you're doing great, your inflammatory markers look great, everything is great. And she looks at me and says, I'm not great. I don't feel great at all. I've gained 15 pounds, I feel tired, I have poor sleep, and I feel weak. My muscles feel weak. And she's right. Her muscles are weak compared to other women of her age and of her race. And this is a study that we haven't published yet, but that we've done here at Hopkins. Is very simple. And we looked at some patients with giant cell arteritis, and we compared them to individuals who are the same age, the same race, and we said, what is the difference in strength, and what is the difference in body composition? And we saw considerable differences. So without a doubt, our patients with giant cell arteritis were weaker than their age-matched counterparts. They were slower when we did gait speed testing, and they had more body fat and less lean mass compared to their age-matched counterparts. So what do we know about aging, muscle, and exercise? Well, one of the disappointing facts about life is that although our muscle strength we maintain about until age somewhere around our 30s to our 50s, but really after age 50, we really start to drop our muscle strength as a natural part of aging. We know that the muscle cross-sectional area of the thigh starts to decrease over time. And the type of muscle that's thought to be lost is type 2 muscle fibers. And I'm going to talk about that more here in a moment. I like pictures, I like visual representations, and this is just a very simplistic view of what I just showed you. So the panels on my left are that of a young individual. This is the cross-sectional of a thigh muscle. So the light gray area here, this is all muscle. This is bone here in the middle. And so here's our young patient, panels A and C, and here's our older patient in B and D. The bottom panels are just coloring in the different compartments. But what you can clearly see is if you just look at the colored pictures here, you see a decrease in overall the amount of muscle that is there that occurs with aging. So this was a study that looked at young individuals. These are healthy individuals without an inflammatory disease, just so you have an idea as to what happens in quote-unquote normal aging. So they looked at younger individuals and older individuals, and they looked at the cross-sectional area of their thighs, and they found that older individuals had a smaller cross-sectional area compared to young. And then if we look at the type of muscle that is decreased in older individuals compared to young, that older individuals have fewer type 2 fibers. So type 2 fibers are the ones, muscle fibers are the ones that are responsible for explosive, powerful types of movements. Type 1 fibers are important for muscle endurance. So if you're a marathon runner, you want a lot of type 1. If you're a sprinter, you want a lot of type 2. And what they found when they did muscle biopsies on these research subjects is they found that actually it's not the number of fibers in the quadriceps. That's not what accounted for the difference. It was actually the size, and there was a lower percentage of the type 2 fibers in the older patients. So then they said, well, if we train these subjects, can we overcome this difference? And they could. So after 6 months of resistance training 3 times a week, when they looked at the cross-sectional area, and this is just for the older patients, they got their quadriceps increased. And when they looked at were they able to increase the number of type 2 fibers, were they able to increase the type 2 fibers size after training, they were able to do that as well. So after 6 months of resistance exercise, there wasn't a change in the number of fibers, but the type 2 fiber size was able to increase. And as I mentioned before, this is where the atrophy is happening with aging. So it's not an insurmountable problem. I want to say just a word about exercise and inflammation. There are data out there that suggest that there are anti-inflammatory properties of exercise. And this is a whole other talk in and of itself and a fascinating area of investigation. Why it's so interesting is that when you exercise, actually pro-inflammatory proteins are increased, but over time, what we tend to see is decreased inflammation. So most of this work has been done in aging and inflammation. Very little has been done in autoimmune and inflammatory diseases, and certainly none of it has been looked at in vasculitis. But it's a fascinating area, and part of why the safety data of exercise in autoimmune and inflammatory diseases like rheumatoid arthritis that I shared with you is so important, because it suggests that even though exercise can create inflammation at the time of exercise. In the long run, there are benefits to suppress inflammation. So let's get back to the patient that I shared with you, our 65-year-old woman with giant cell arteritis, who was talking about these symptoms at her visit. And so I always like to remember this statement, which is before making a plan for the future, you have to acknowledge where you've been. And so it's always important before deciding to embark on an exercise program that I take a history of what type of exercise someone is familiar with and what they've done in the past, and what type of goals that we have for that exercise. So for my patient, previously before GCA, she had done some cardiovascular exercise and she was a member of her local YMCA. In the past 6 months, she'd been walking in her neighborhood about 30 minutes per day, most days of the week. Over the past 2 weeks, she had been walking regularly, and she'd never had any experience in terms of strength training. So we discussed what our goals were, which were to increase her strength because she has this the symptom of overall weakness, and we were going to try to decrease fat because she'd gained about 15 pounds in starting corticosteroids. So the two of us together came up with a prescription for her exercise, and this is her prescription. I referred her to physical therapy for detailed instructions and direct supervision in a progressive resistance training program. Remember, she did not have any experience with resistance exercise previously, and often that's a barrier to patients starting a resistance exercise program. But everybody is always excited to learn. They just need to be taught. And physical therapists are very well trained at teaching resistance exercise programs. So a progressive resistance exercise training program may look something like this, and this is just an example, which means that the number of repetitions and the number of sets can increase slowly over time by increasing the intensity or the amount of resistance. I recommended that she continue her walking regimen, and we talked about rejoining the YMCA. So I don't know if anyone is familiar with who this individual is, but this is Frank Zane, and he was Mr. Olympia in the 1970s. But I think the before and after picture is just so striking that shows, I told you about some of the changes that occur to muscle with aging. However, with continued dedication to resistance exercise, the changes that happen naturally with aging are not inevitable. So I think that we can all agree, and what hopefully I've been able to show you some data for, is that exercise is good for our patients. And exercise really is good for everyone, especially those with chronic disease and certainly the physicians who are taking care of them. But of course, you always have to get started before you can get to the finish line. So in summary, just to review the things that we've talked about this afternoon, we know that fatigue and muscle weakness are very common in rheumatic diseases. We don't have good pharmacotherapies to treat these things, and we probably shouldn't, because and exercise is a safe and effective intervention. We have to acknowledge that it is true. Our lack of knowledge as healthcare providers about exercise can be a barrier for our patients' exercise regimens. And that's also where patient education and patient empowerment becomes so important. A prescription for exercise should be specific, goal-oriented, and allow for progression. It should not be, it's not physical activity. It's different than physical activity. Although it's always good to try to increase your physical activity if possible. Parking a little bit further away from the front door of the store. Those things are excellent. Taking the stairs if you possibly can. But it still doesn't actually count as exercise, because your exercise prescription then can be adjusted as your goals may change over time as well. There's a lot that we have to learn about the best prescription for exercise in vasculitis. And there's a fascinating area to explore about the anti-inflammatory properties. We desperately need work for this we need work in this area, and this is something that we're trying to do some exploration with at Hopkins, but there's certainly a lot of work to be done here. Although circumstances such as age, comorbidities, and injuries may require a change in the formulation or the dose, there is rarely an instance where exercise should be discontinued. And that's an important point to remember too. Remember, I shared with you the data from the rheumatoid arthritis study, where when patients completed the study, they didn't continue to exercise and they had no benefits. The problem was that the exercise that they didn't engage in any type of exercise. There is no doubt that health changes over time and over the lifespan. New things may occur, diseases may flare, people may fall and break a hip or a leg, and it's going to change what your current exercise prescription was. It doesn't mean that there's no exercise that's recommended. It just has to change, and it should change. It should change based on someone's health and what else is going on with their body at the time. So with that, I will conclude, and I would be delighted to answer any questions that the audience has.
Great. Thank you very much, Dr. Manno. So we've had several questions submitted via social media channels, and I've also asked Kaylin Young, the network manager for the VPPRN, our patient-powered research network, to join us. So Kaylin, one of the first questions I saw, it resolves around when you talk about research being done, would you recommend research, like, would it incorporate all the different forms of, or many of the forms of autoimmune diseases, or would you want to do it specifically in the field of vasculitis?
So I think that there is a role for both. So obviously I'm partial to vasculitis because I take care of predominantly vasculitis patients. And I'll even say specifically in the world of vasculitis, I think there are a lot of important questions that we don't have answers to with regard to different forms of vasculitis. For example, with large vessel vasculitis, such as Takayasu or giant cell arteritis, where we may see differences in terms of strength because of differences in blood flow in the upper and lower extremities, what types of exercise programs may be appropriate for someone with a large vessel vasculitis and will be maximally beneficial, that may be a different question than someone with ANCA-associated vasculitis or GPA Wegener's, where we don't have large vessels which are typically involved. So I think there is a role for both, and I think both should be done. Like I said, we've had to extrapolate from rheumatoid arthritis into the world of vasculitis, and some of that comes from the fact that just rheumatoid arthritis is a lot more common, and often it's easier to recruit patients for those studies. But I think that there is a role for looking at disease-specific changes. And it's not only about a lot of the work in exercise and autoimmune disease has been looking at body composition and strength, but especially in the world of vasculitis, I think an area that hasn't been explored is looking at blood flow, especially in the types of large vessel vasculitis. How does blood flow change with exercise? Are there certain exercises that may really help that? So the answer to the question is both need to be done, because although there are similarities between these diseases like rheumatoid arthritis and vasculitis and myositis, there are significant differences that I think really need to be focused on as well.
Great, thank you. Another question that came in was about a patient who's on dialysis 3 days a week, and she was wondering, are there any things like swimming in the pool? Would that be a concern, or would it be okay for her to do that?
It usually is. I mean, a pool should be okay. It always depends on the dialysis access. If it's a more permanent access, such as a fistula or a graft, it's just taking those types of precaution for the dialysis access. But oftentimes, so a pool can be used in many different ways. So it doesn't always have to be submerged type of swimming, but even pool aquatic exercise. Certain places will have water treadmills where you can be walking but being in the water. And the benefit of that is that it takes a lot of the strain off of the joints. The water can be temperature controlled, which can be very effective at calming inflamed or angry or arthritic joints as well. So being in the pool, even from a range of motion standpoint, can be incredibly beneficial. I think that from a dialysis standpoint, the only caution there would be the dialysis access and make sure that that's being safe.
Great, thank you. I know my YMCA pool, they keep their water much warmer.
Yep.
We're fortunate, we have a swimming pool for the lap swimmers, and then they have a pool that they keep which is much warmer for a lot of the arthritis classes that they offer, which is nice.
Yep, absolutely.
Great.
Absolutely. It makes a big difference. Warm water is much kinder to joints and muscles than cold water is.
Mhm. Great. Another question we received, I'm a 21-year-old male patient with GPA. Can you advise me on whether I should take muscle mild calorie replacement drinks? Does it pose any issues with my treatment? And he has Rituxan and Prednisone in parentheses. And I know you can't comment directly on a patient care, but any ideas on this?
So I think the question is getting at the issue of supplements and nutrition. I'll focus on, I mean, there's all sorts of supplements that are out there, but nutrition and dietary supplements in particular. Um, and of course, it depends. It depends on what else is going on with someone's health. So if someone has kidney involvement from their vasculitis, they may be on may want to be a little bit careful about how much protein they're taking in, how much potassium they're taking in. In someone who has normal kidneys, then most of the meal supplementation type of drinks or meal replacement drinks are okay. My only caution with any meal, quote unquote, meal replacement drink is that usually they are designed for weight loss. The much more effective supplement would be just to use a whey protein or some sort of protein supplement itself. So whenever you're doing resistance training, if you're trying to build muscle and you're trying to build strength, you've got to feed that muscle. So this gets back to my disclosure at the beginning, which is that nutrition and exercise really go hand in hand, and they're so important to think about together. And so if you're trying to fuel your muscles want protein. And so most of the sports meal replacement type of drinks and bars and so on, they're going to be heavy in protein. What I'll also say, though, is that a lot of meal replacement drinks will also be high in fat and cholesterol as well. So you have to be careful about the balance of those things. So the question becomes, what is the goal? If the goal is to increase muscle, then you're probably going to save some money and on the muscle milk and just use a protein supplement such as whey protein that you could mix either with water or juice or something else. If the goal is actually weight loss, then we're having a bit of a different conversation in terms of what supplements would be appropriate, but that really comes down to very careful nutrition planning, and I rarely recommend using meal replacement in terms of weight loss because it's just not practical in the long run, and it's much better to make lifestyle changes instead of quote-unquote diets.
Great, thank you. Kaylin, do you have any questions?
Let me see, and we will check the question box. So if you have one other in the interim, then I'll try and pull up all the ones that have been submitted.
Okay, great. So many hospitals offer exercise programs. Is that something somebody wanted to know? When they work with a physical therapist to do rehab after being in the hospital for a while, what should they tell their physical therapist? I know that's different than exercise, but often people, if they've been in the hospital for a while, they're, regaining walking or whatever. They wanted to know, what should they tell their physical therapist? And then the second question, what about their trainer, if they are lucky enough to work with a trainer?
Sure. So it's probably a good bet that your physical therapist or trainer will have never heard of vasculitis. So it's important to tell them, but recognize that that's probably not going to mean much to them. It's certainly important to let them know if there's any areas that are particularly problematic for you. So if your knees have been a real problem, or your shoulders, or your hands, or your wrists, or if there's any part of you that has been a problem, that's been a problem area, that's been painful or swollen or anything along those lines. It's important to let them know something about your medications. Once again, they're not going to be familiar with your immunosuppressants, but this really speaks more to prednisone for sure. Just letting them know what types of doses that you're on. And then the last part is, I generally, for my patients with vasculitis and other types of, and arthritis, I will generally tell them, and this becomes less of an issue with physical therapists who are very well educated in this. With personal trainers, there's a great deal of variability, so I will tell them that any exercise program should be low impact. So especially with personal trainers, and in 2017 there is a huge movement right now for quick, high-intensity workouts that are high velocity, and these are things that personally I don't think are very good for most people, but certainly when someone has an autoimmune inflammatory disease, the medications that you're on, things that are high velocity, high impact, really should be avoided. So doing things like box jumps and things that have quick change of direction, trying to avoid those things.
Great, thank you.
Thank you.
Caitlin, I see there's a couple questions in the question box. Do you want to moderate those, please?
Yeah, that'd be great. So the first that was submitted was a question about going back to the gym. So one of our participants writes, I was very fit when diagnosed with GPA 2 years ago. I exercise at home, but I'm hesitant to go back to the gym or yoga studio because of the immunosuppressants. Any thoughts?
Yeah, thank you whoever brought that up, because it's a question that we get often, and you're already ahead of the game, whoever asked this question, because you're thinking about it. So it should not be a barrier to you going, if that's what you want to do. So you are right, and I certainly don't know anything about your personal immunosuppression right now, but our patients are immunosuppressed, there's no doubt about it. But that doesn't mean that life should be lived in a bubble by any means. And so what I will tell my patients about getting back to the gym or to the yoga studio is two things. One of the biggest problems that we run into is that when they go back, they expect their body to be exactly the same as the last time that they went, which may have been before they were as sick as they had become with their vasculitis. And so just recognize that when you go back, that you have to start off slow, even slower than you ever thought that you would, even though you've been exercising at home, which is fantastic. But when you're going into a new environment and you're going back to some things that you haven't done in quite some time, you have to start off slow. In terms of the infectious risk, it should not be a reason not to go to the gym, and it's not a reason. However, it does mean that you want to be more of a germaphobe at the gym than you've been before, which does mean carry your Purell or your hand sanitizer with you when you finish on a machine or on the treadmill. Wash your hands. Of course, you can wipe down the equipment and so on, but the most important thing is actually going to be your hands. So washing your hands and using your Purell. And from that standpoint, really, the infectious risk isn't going to be, it should be manageable. I can't tell you it'll be zero, but it shouldn't be a reason not to go back, as long as you exercise those types of precautions.
Great, thank you. The next question is, and this one I think we've received several times, but in a different phrasing. But what types of muscle and joint pain should concern us? Sharp, dull, throbbing, and where do you differentiate between this is soreness, disease soreness versus this is exercise soreness, etc.
Yeah, and the reality is it can certainly be difficult to sort through. So some clear warning signs if you are doing an exercise or you're doing some sort of fitness activity and you have the sudden onset of a pain, then that is a red flag. Stop what you're doing and rest. If it goes away, then you can resume exercising, but I would choose something different. If it doesn't go away, then that's certainly something to seek medical attention for. Muscle soreness can be very tricky as well. So whenever muscle soreness is something, so scientifically there's a lot that we don't understand. There are some people who develop a lot of muscle soreness even with minimal activity, and there are some people who never develop muscle soreness at all. So you have to learn a little bit about your body as to where you fit into that spectrum. The majority of people, the average number of people are going to develop some degree of muscle soreness whenever they do something that is different. It doesn't even have to be particularly strenuous, but if it's using different muscle groups in a different way, they're going to develop muscle soreness in 24 to 48 hours after they did that activity. Muscle soreness is okay after exercise as long as you can still use that muscle group and it dissipates after about 4 to 5 days. If the muscle soreness is severe, meaning that it's affecting your everyday life and you're noticing it on an everyday basis, or it's affecting how you move, that's not okay. And sometimes that means that you actually really need to stretch out that muscle some more, and it probably means that whatever you had done to provoke that, you need to dial it back a little bit. You're right in that inflammatory diseases love to cause muscle and joint pains as well. Oftentimes my patients will tell me that they can notice a difference between when it's their disease, because it'll often be accompanied with other types of symptoms, which might be fatigue or fever or swelling in the joints, which is different than some of the muscle soreness, for example, after fitness or activity. So it can be very tricky, but it's also something that's important to talk to your doctor about, because that's part of our role as your physician, which is to help you sort through that. And if you're starting an exercise program, that's where the slow ramp up of the program becomes so important, because if you're starting slow, you're less likely to run into trouble with injury or soreness than if you come out of the gates at 100 miles an hour.
Great, thank you. And I think those were the only questions that were submitted via the chat box. Joyce, if you have any others, I think that
I think we're good. Okay, great. Thanks, Kaylin. So that's all the ones we have submitted, and we're a couple minutes over the hour. So I think we'll go ahead and wrap up the webinar. Dr. Manno, thank you again for joining us today and sharing your expertise in this field. We just appreciate all that you do for our patients, and also for your volunteer work with the Vasculitis Foundation as a consultant. You're always willing to help us, and we just really appreciate it.
Thank you so much. Thank you for the invitation. It's my pleasure.
You're welcome. Again, I'd like to thank everyone for attending the webinar today. I'd also like to remind everyone to consider joining us in Chicago, June 23rd through the 25th for our International Symposium. And I'd also like to welcome everyone to Vasculitis Awareness Month, which starts on Monday. Can't believe it, but May is almost here. So if you have any questions or would like any follow-up, please feel free to email the VF office. And I welcome any questions, comments, and just want to wish everyone a good afternoon. Thank you.
Thank you, Joyce.